Hello, this is Mark Kochenderfer. This is Mark Kochenderfer from Blue Ridge Cancer Care, and I'm also an assistant professor at the Virginia Tech Carilion School of Medicine. And today I'm going to talk about pancreatic cancer. Um, so let's kind of look at what we're going to talk about. We're going to talk about pancreatic adenocarcinoma. I know there's a few other types of pancreatic cancer, like pancreatic neuroendocrine tumor, that are much, much less common, but this is a talk about what we typically deal with the usual kind of pancreatic cancer. I will talk about kind of staging and how we approach pancreatic cancer, and we'll also do an overview of treatment and also, just as importantly, an overview of how we manage symptoms from pancreatic cancer, which are often quite unique when it comes to pancreatic cancer. And we'll also have a case to kind of put it all together at the end. So, I guess the first question that we need to look at is how does pancreatic cancer present? And this is one of the real challenges with pancreatic cancer. Unlike some cancers where you can feel them or see them or they cause symptoms very early, pancreatic cancers can grow for years and we don't even know they're there. Um, some of the most common ways that they present are with painless jaundice. A patient just suddenly becomes very yellow from jaundice, from bilirubin backing up in the liver and going into the bloodstream, because the common bile duct's obstructed by the pancreatic cancer. A new onset of diabetes in a patient older than the age of 60 can also be associated with pancreatic cancer. And weight loss, depression can actually be very common with the uh, new diagnosis of pancreatic cancer. And this is not after a patient's diagnosed, this is before a patient's diagnosis. It's what's called a paraneoplastic like syndrome. It's caused by some of the bad cytokines and things that are put off by the pancreatic cancer. Abdominal pain certainly can cause pancreatic cancer. And as I've mentioned, nearly half of the pancreatic cancers are metastatic at presentation. Um, and let's take a look at the anatomy of the pancreatic cancer. Um, Here you can see um, the pancreas and the stomach and the small bowel coming off the stomach. And, you know, what's really impressive about this picture is just how much anatomy dictates what we can do as far as the treatment of pancreatic cancer. You can see there's some extraordinarily important blood vessels running right beside the pancreas, especially um, the superior mesenteric artery, which is one of the largest arteries in the body. The other thing you'll notice is that the pancreatic duct runs right through the pancreas, and that the common bile duct dumps into the small bowel from the liver and the gallbladder right at the head of the pancreas, which really nestles itself up right against the small bowel here. So there's very little room to stick a cancer in there without causing lots of problems. And also, it's incredibly difficult to resect these pancreatic cancers, particularly the pancreatic head cancers, which are most common, because there's so many critical structures in such a small area of the body. And this is just a figure of shows the biologic features of pancreatic cancer. We won't spend a lot of time on this, but um, one of the problems with pancreatic cancer that makes it so difficult for chemotherapy to get to it is it causes a lot of um, fibrous type tissues, which kind of block the the chemotherapy or other treatments from getting at the cancer. That's kind of what you're looking at with this picture. What causes pancreatic cancer? I guess that's always a big question everybody has. And unlike, say, lung cancer and smoking, there's no um, extremely strong factors as far as behavior that lead to pancreatic cancer. So I often tell my patients there's really nothing you ate, smoke, or drank, or didn't eat, smoke, or drink that caused this cancer. You can see there's a very slight increased risk with smoking. Longstanding diabetes can also slightly increase the risk. Chronic pancreatitis slightly increases the risk. Maybe obesity does. So, little bit of risk factors, but not a huge smoking gun in the vast majority of cases. We don't know why a patient got pancreatic cancer. What we have found much more recently is that there are a number of pancreatic cancers that are inherited. And you may have heard of the BRCA1 and 2, the BRCA genes from breast cancer, and PALB2 is an associated gene. These have been found in about 3 or 4% of breast cancers now. You can see there's some others that can lead to breast cancer. There's a hereditary pancreatitis syndrome, which increases the risk of pancreatic cancer 50-fold. Also, hereditary, or I'm sorry, familial atypical mole melanoma syndrome can increase the risk, as well as Peutz-Jeghers syndrome. So we're doing, and this is important. I put this slide in here because now we genetically test every patient with pancreatic cancer to see if they have any of these syndromes, as it may make some changes in their therapy. Um, and this is just looking at this briefly the staging. Staging is what we do to determine the extent of a cancer, and it's kind of every cancer has its own unique staging system. As and this is pancreatic cancer staging system on the slide. Um, and basically, when we look at staging, we look at how big the primary cancer in the pancreas is, whether the lymph nodes are involved, and most importantly, has the cancer spread anywhere else in the body. If the cancer has spread, then it's stage 4 and it is not curable. If it has not spread, there may be the potential for cure. But that all depends on, like I said, on the ability to surgically resect the cancer. We can't cure pancreatic cancer without surgical resection in 2021 in the vast majority of cases. And staging is important because staging dictates treatment. And this is a breakdown. 50% of patients at diagnosis are stage 4 or metastatic. Those patients are only going to receive chemotherapy. We can't cure those patients, unfortunately. But we can potentially prolong their life significantly with chemotherapy. 35% of the patients fall into what we call unresectable, which means the cancer hasn't spread elsewhere in the body, but unfortunately, we can't operate on them. Some of these unresectable patients could possibly be converted to being resectable with chemotherapy and radiation. And that's a hot area of investigation right now. And then 15% of pancreatic cancers would be resectable at diagnosis without any treatment up front. And staging matters because staging is set up to correlate with how a patient is going to do and what their survival is going to be. You can see here the differences in survival based upon stage. This is overall survival over here on the left. This is the time of survival in months. You can see if you're stage 1, they have an overall survival at 5 years of 40%. But if you're stage 3, the overall survival is only at 5 years is only about 10%. And this is just survival by the number of nodes is also important, and and how T stage, meaning how big the primary tumor is. And this is sort of a nice slide that shows the continuum. It's from the New England Journal of patients with no arterial or venous involvement are resectable. As you can see at the bottom, and the more involvement you have, be it venous involvement or especially arterial involvement, those become unresectable, and distant metastases if the cancer's already spread elsewhere, obviously that's unresectable. So you can kind of get a feel for the continuum that we deal with in pancreatic cancer between resectable, unresectable, and metastatic are the three categories that we'll keep coming back to as we go through this talk. So the first category is borderline resectable or just resectable, and these patients don't have the arterial involvement. They may have minimal venous involvement, no encasement of the superior mesenteric artery. So basically, we could operate and take the cancer out as soon as it was discovered. Like I said, this is the minority of cases, only about 15%. So these patients can get surgery up front if it's in the head of the pancreas, which is most common, or even the neck. The Whipple procedure, or the other name for it, the pancreaticoduodenectomy. It's an 8-hour procedure done by a very specialized surgeon. Here in Roanoke, we are fortunate to have Dr. Lumbasa who trained at City of Hope, who's an excellent hepatobiliary surgeon to perform this procedure. This is the best case scenario in pancreatic cancer. And sometimes, even if a cancer is resectable now, we're kind of trending towards doing some chemotherapy first to try to make the cancer even smaller and potentially kill any microscopic cancer cells that could have gotten loose that we can't see. One of the things that helps us in that decision is a protein that the cancer puts off in the blood that goes by the name of CA19-9. And CA19-9 should be less than 100, or I'm sorry, less than 35. If it's more than 100, we definitely want to do chemotherapy because the risk of the cancer coming back someplace else is about 50% over the next 3 months. Before we put someone through a surgery, we want to try to do that chemotherapy to see if we can kill any of those microscopic cancer cells before they have a chance to take root and come back as metastases. Because if we wait until they're big enough to be seen on a CT scan, then it's too late to cure them. If we can get them when they're small and vulnerable with the chemotherapy, then perhaps we can sterilize the cancer cells that had spread elsewhere, and hence give the patient a chance for cure. So this is Dr. Lumbasa, my colleague, the surgeon's contribution. If you're going to do a cancer surgery, the goal is to get what's called negative margins, which means you got all the cancer out and you left, and there was a clean margin around it, so that we know that we did everything we could to get everything that could be seen. There's no point in doing a cancer surgery if you can't get it all out. And like I was saying, there's very advanced surgical techniques, and management of these patients is very complex and multidisciplinary. After you've had surgery, some patients, after they've undergone pancreatic duodenectomy, could develop diabetes. They can develop nutritional problems with absorption of food and have to go on a medicine called Creon, which is enzyme replacement therapy from the pancreatic enzymes. that help digest your food. If you don't have a pancreas, you're not going to be making them, and that's really important to your GI tract. So lots and lots of things to do post-operatively in these patients. And the other thing that I do post-operatively is give chemotherapy. Chemotherapy are strong medicines we put in the veins to kill cancer cells. And you can see here, this is kind of our best data. The regimen that we often use after surgery is called modified FOLFIRINOX, which is a mouthful, but it's really just a cocktail of chemotherapy drugs that give patients almost a 50% chance, if they've been resected with negative margins, of being alive without disease and disease-free at 5 years, which is tremendous advancement over the 10% we were doing without chemotherapy with just surgery just a decade ago. So let's move on. We talked about the patients that were resectable. Let's talk about kind of, let's skip that one. Let's move on here to unresectable. These are patients that have cancers that can't be resected, meaning you can't cut them out and make them go and cut them out up front because of their involvement usually with the vasculature, the blood vessels. And this is one of the most difficult areas to discuss from prognosis-wise, because there will be a small number of patients that we can basically convert from unresectable to resectable and potentially cure. But unfortunately, that's not the majority of patients with unresectable pancreatic cancer. So in general, we usually do chemotherapy and then chemoradiate, followed by potentially chemoradiation. There's also several other, it's a hot area of research, and try to convert the patients to a resectable status so that they could have surgery. So local chemoradiations, when we give chemotherapy and radiation at the same time. We often do that with in pancreatic cancer that is unresectable, as a way of trying to control the cancer, if not, even if we can't convert it to a resectable status. A new thing that a lot of institutions are experimenting with now is called total neoadjuvant therapy. Total neoadjuvant therapy is when patients are given both chemotherapy and radiation and chemotherapy prior to the attempt at surgery. Neoadjuvant means prior to surgery. So we're trying to do all of this up front to try to give the patient the best chance to get to surgery for a hope of being cured. So this is a real hot area of research. We actually have a clinical trial with this right here in Roanoke with Blue Ridge Cancer Care. And the reason we want to do that is we see that patients do better when they receive the chemotherapy and they respond to it, and we can get that CA19-9 down. We have a better chance of them living a long time without the cancer coming back. And here you can see, if the more risk factors you have with pancreatic cancer, the worse you do, which isn't surprising. So then let's talk a little bit about what half of our patients with pancreatic cancer are going to present with, and that is metastatic disease, cancer that has spread from the pancreas to elsewhere in the body. Unfortunately, like I've said, this is not curable. It is treated typically with chemotherapy alone. We may do some radiation for pain control or for palliative reasons, but it's going to be different than the radiation I just mentioned in the patients with cancer that has not spread outside the pancreas. And the goals of care and supportive care in these situations are very, very important. Most common place for cancer of the pancreas to spread is the liver. And second is the peritoneum, which is a big imagine a big piece of saran wrap that kind of keeps everything in place in your abdomen. And that's where patients can get fluid buildup as that saran wrap gets crinkled by the cancer and causes pockets of space, which can fill up with fluid called a ascites as the cancer grows on the peritoneum. And these are some of the trials looking at survival with different cocktails of chemotherapy in metastatic pancreatic cancer. And unfortunately, in metastatic pancreatic cancer, we're not doing as good as we would like. Um, as you can see, the median survival is measured in months, and even our best case scenario with our newest regimen called FOLFIRINOX is a little bit under a year of median survival, although we do have patients that do a lot better than this. As I mentioned earlier, genetics consult is now a standard recommendation in all patients with pancreatic cancer. We're finding an increasing number of molecular mutations that are causing the cancer, driving the cancer, and we're developing an increasing number of medications that are targeted therapies instead of the untargeted chemotherapies to try to control these cancers. So it's an exciting time in pancreatic cancer. So we have made a tremendous amount of progress, although as you can see, there's still much to be done. And these are just some of the different mutations you see. I mean, none of them are incredibly common other than KRAS, which we don't have a target for, but you can see the BRCA and ATM, which is some of the ones that we can test for and can change our treatment. They're about, I think it's about 4 or 5, 10, it says 10% here, and some different things that we figured out here with oncogenes and tumor suppressor genes that have gone wrong and are causing the cancer to develop. One example of a targeted therapy is called a PARP inhibitor, which we use in the BRCA pancreatic cancers. This was first discovered in ovarian and breast cancer, and we're now using it in pancreatic and prostate that are BRCA-driven cancers. So that's exciting. You can see how this tail on the olaparib kind of settles out here and continues to go versus the patients that did not receive it. Switching, that's kind of a brief overview of how we treat pancreatic cancer. I hope that was not too much. Let's talk about palliative care and symptom management, which is just as important as our treatments in pancreatic patients. Because this is the kind of cancer that once it presents, and especially if it's metastatic, it can cause a lot of symptoms. There's a lot of different things that can go wrong with these patients. Let's start with what is palliative care. And this is a quote from Tom Smith, who's used to be at Johns Hopkins, and he is he's a leading palliative care oncologist. And he defines palliative care as medically appropriate goal setting, open and honest communication, and the best symptom assessment and control. So it's setting goals that are reasonable in the context of the medical situation, communicating that goal and the patient's goals as well, because each patient has their own goals, especially in stage 4 where there is no cure, and also controlling patients' symptoms. And another quote from Tom Smith, I thought the nurses do palliative care better than doctors, which has a lot of truth in kind of differences between sort of the approach and the way doctors and nurses are trained. So here are some guidelines, some different things that can happen with pancreatic adenocarcinoma. One that we worry about is biliary obstruction. Like I was saying, that's when patients get jaundice because the bile ducts are um, are clogged, and a stent can be placed to open the bile duct back up and keep it open. In those situations, sometimes you can have an obstruction of the small bowel itself coming out of the pancreas, or I'm sorry, out of the stomach. You can place a stent there. Um, we can block the celiac nerve, which runs through the pancreas and can be irritated in pancreatic cancer and cause significant pain. We can numb that nerve by hitting it with a numbing agent in a procedure, especially one where they go down the stomach with an endoscope. Um, Depression, we can treat that. We also have to watch out for blood clots in pancreatic cancer because there's a real increased risk in cancer in general, but especially in pancreatic cancer. Um, Also have to watch out, as I mentioned, for pancreatic insufficiency. And there can also be bleeding from the tumor site. So those are kind of some of the things we deal with. And I've also added this list nutritional status, which can become quite difficult. People can lose weight and lose their nutritional status with pancreatic cancer. The stenting. So this is that's what I just mentioned. Is putting a small stent into the bile duct. There's a picture of it to keep it open. To just basically you're propping the door open so the bile can drain. Pain control is extraordinarily important in any cancer, and especially in pancreatic cancer, because pancreatic cancer can cause significant pain. The celiac nerve runs right through the pancreas, and pancreatic cancer can become irritated. Um, we use narcotic pain medications. We use the celiac nerve block. Sometimes we use adjunctive pain medicines such as ibuprofen or Tylenol or something else. Sometimes we even use a short course of radiation to try to control the pain. So when we use all these things together in concert and individualize it to each patient to do the best we can to control their pain while not causing a bunch of other side effects with the pain medications and therapies. This is just another picture of stenting, or this is a celiac nerve block. See, they're going in with the pin right into the pancreas there to numb the nerve. Yeah, the obstruction can happen. The duodenum's right. The pancreas kind of nestles into the loop of the duodenum, and it can, if there's a big tumor in the head of the pancreas, it can actually obstruct the duodenum. So sometimes we even stent that open or bypass it with a surgery. There's some examples of those stents. There's esophageal stents. We use the same ones in the duodenum. Nutrition, weight loss is very common. We get a nutrition consult with every pancreatic cancer at the cancer center. Um, and as I've mentioned a couple of times, sometimes people need pancreatic enzymes to help digesting their food well. And in the metastatic setting, we usually counsel against PEG placement. There's no survival benefit for that, and that can actually cause significant problems. Anticoagulation. Um, I think, like I mentioned, there's increased risk of blood clots with pancreatic cancer. That's something that needs to be talked about. There's risks and benefits to that. Depression is very common with pancreatic cancer, even more than in other cancers, even before the diagnosis is known to the patient. So it is a biological depression beyond the issues with the diagnosis of the cancer and effects of of the treatment of the cancer. So I have lots of discussions about antidepressants with these patients. We also try to discuss their goals of care and what their goals are, and make sure those goals try to be realistic and line up with what the medical situation would allow. This is an example of a values assessment that we give to our patients to try to tries to help us understand what's important to them, and it's just 10 short questions, kind of asks, what's important to you, and what do you think about, um, if you're in a situation where you can't be cured. So that's one of the things that we do that can be really helpful in opening these tough discussions with patients. So I'd like to close with a case. I have a couple of slides left. And this is a true patient, 69-year-old woman found to have metastatic pancreatic cancer with liver mets and duodenal invasion. So she is not curable, like 50% of patients with pancreatic cancer at diagnosis. She presented with the painless jaundice and partial obstruction symptoms, usually nausea and vomiting. Um, she had a 5-pound weight loss. She was interested in having chemotherapy. So some patients, if they told you, "Well, you can't be cured," they say, "I just want to go home and enjoy what time I have left. I don't want to try chemotherapy." And some do, and that's a personal decision. So she was having some significant pain. So kind of asked, what should we do? Well, what we did lots of things for this patient. We put a stent in to the common bile duct, to try to relieve that jaundice. We did a celiac nerve block into the celiac nerve to try to, which really improved her pain. This patient had a gastrojejunostomy tube placed, which basically bypasses the duodenum. We kind of take the stomach from the stomach to the jejunum, the second part of the small bowel, and bypass that real big curve around the pancreas where that obstruction was occurring. She had a genetics consult. She had a nutrition consult. She had narcotic pain meds. She was having some liver capsule pain. She had her obstructive pain improved um, with Reglan until jejunostomy was placed. We put her on antidepressant. We had discussions with palliative care and goals of care discussion and values assessment, as we showed. And she's currently on a clinical trial, receiving standard chemotherapy plus an experimental agent that we have here at Blue Ridge Cancer Care. And she's doing quite well. She's responding to therapy. She's now about 6 months out from her diagnosis. So thank you very much for listening. I hope you all have a great discussion. And I hope this was helpful to you. Um, Everyone take care. If you have any questions, I'd be happy to answer them. I'm sure um, they can be routed through the moderators back to me. Everyone have a good evening. Thank you very much.